Thanks, Katrina, for the kind invitation. And it's a kind of repetition for the audience because I presented the same lecture in Thessaloniki last week. Um Now, after coming here, I understand why the golden visa rates have increased because every week in India, we get a notification like apply for a golden visa in Greece. After coming here, I understand why it's become more expensive. It was $250,000 before, now is $800,000. No disclosures pertaining to this talk. I'll keep the lecture in this way. The need for a new diagnostic tool in the mediastinum. Why we need a new diagnostic tool? Because when we did the first cryobiopsy, I have sent some of the cases to Dr. Pallav also, and then he said I have a good diagnostic yield of around 90% with the needles. Why you need such a complicated thing going in the mediastinum except for lymphoma cases? And then how the evolution of mediastinal cryobiopsy happened, and when to perform the cryobiopsy procedure, whether you do it as the first procedure of choice in the unit, or you limit yourself to cases where you have a negative diagnostic yield and then you do the procedure later, and different technical aspects of mediastinal lymph node cryobiopsy, and what is the new published literature, because this is one of the most discussed topic in the current day intervention pulmonology after robotics and cone beam CT, especially in the Southeast Asian population. And we all know that EBUS TBNA, the conventional method with the needle, is the gold standard for diagnosis and staging of lung cancer. But it has a sensitivity of around 66 to 95% and a specificity of 99% for staging the mediastinum. And when we talk on the need for new diagnostic tool, we all have patients who have negative diagnosis on needle-based EBUS TBNA. And then when we submit them for VATS biopsies, they have a diagnosis of lymphoma. This is one subset of population where we need a better tool to get tissue. And also in advanced stages of sarcoidosis and some benign mediastinal pathologies like TB, where the diagnostic yield of conventional needle-based TBNA is not as good as that in lung cancer patients. And then if you see the meta-analysis from sarcoidosis, the pooled accuracy is only, diagnostic is only 79 to 80%. So when we have a discussion on in the periphery, why we need robots? Well, because we want to move from 75% to 90%. And then that is one reason why in the mediastinum also cryobiopsy could be superior to needle biopsies. And also in lung cancer patients, not that all patients have diagnosis on needle based, because many times the pathologists complain there is a lot of blood, I cannot see the cells properly. And then there are some misdiagnoses that happen. And in the increasing era of molecular analysis, we have to submit all samples for a 52 gene panel in our population. So I think more tissue is needed. And if you look at the evolution of biopsy tools in the periphery in transbronchial mediastinal transbronchial cryobiopsy for ILD, we have completely moved from forceps to cryoprobes, because as a tool, cryo is the better tissue acquisition tool compared to needle and forceps. And those who are happy with the tissue acquisition with the conventional needles still tried so many ways to improve their diagnostic yield by increasing the size of the needle, which did not improve the yield. And also there are changes that happened in the shape of the needles, materials used. And then there was interest in forceps biopsies also few years before, but it was not rapidly adopted into clinical practice because of the complexity and the availability of the tool, that is the small forceps. And also recent publication from the chest also has changed their minimum number of passes from 3 to 4, because there is more tissue that is needed nowadays for analysis. And when we talk on the evolution of mediastinal cryobiopsy, the concept, the proof was from China, when they first introduced a knife to put cryoprobe into the mediastinal mass. It was not a lymph node, but it was a mass. With a freezing of 15 seconds in a 4 centimeter lesion, they were able to get a diagnosis of seminoma. So this was the first publication on mediastinal cryobiopsy. And then came the randomized controlled trial. So the initial RCT showed better diagnostic yield in benign diseases and also rare tumors, but there was no significant difference between the EBUS TBNA and EBUS mediastinal cryobiopsy in normal lung cancer patients. That was one observation from the initial studies. And if you see the subset of patients of lymphoma in this, only one of the patient had diagnosis on TBNA, and all the 7 other patients had diagnosis on cryobiopsy. And also there was statistically significant diagnostic difference between needle and cryobiopsy in sarcoid and tuberculosis patients. So this is a very important thing for our region. And this RCT also showed that when you do the combined approach of needle and cryo together, there is improved suitability of the tissue samples for molecular and immunological analysis for non-small cell lung cancer. And then we made the first publication on using the needle to create the tract, because technically there are many ways how you enter the mediastinum. So this is the first publication from our center. Though we did not have any difference between the diagnostic yield compared from needle to that of cryobiopsy in the first 4 cases, but it was just looking at the feasibility of the procedure. And then few studies showed that even in lung cancer patients, the diagnostic yield is superior when you do mediastinal cryobiopsy compared to conventional TBNA. This is from a Spanish group, where they showed that even in lung cancer patients, they had a good diagnostic yield. And this is one paper coming from Malaysia. If you look at how many passes you should do in the mediastinum, the diagnostic yield plateaued after 2 or 3 cryo passes. Though the sample number is small in this population, but they showed that after 3 biopsies, the diagnostic yield really plateaued when you do mediastinal lymph node cryobiopsy. And then 2 or 3 meta-analysis published recently, and there is one paper from Professor Politi also looking at the yield in patients who have initial negative biopsies, and also in rare lesions like Castleman disease and silicosis. There is improved diagnostic yield with cryobiopsy compared to TBNA. But this paper did not show much difference in the diagnostic yield in non-small cell lung cancer patients. Coming to the technique of mediastinal cryobiopsy, the most important thing is the tract creation, in my opinion, how you create the tract. So now we moved on in our center doing the cryobiopsy without using the needle. So we don't put the needle in patients. We just go as a first procedure of choice for all the patients who present with mediastinal disease. And then we use a small electrocautery knife here, as you can see in this video. And then just get the cautery knife out and then press onto the mucosa. Make 2 or 3 cuts in different angles by just using the thumb, and then create the tract. Once the tract is created, now you can see you just maintain the scope without much movement, and then do a memory of the lymph node on the ultrasound image where you have done the cutting, because sometimes when it bleeds, you miss the spot where you can enter back. So you just keep a memory, and once the cut is made, you just pass the cryoprobe into the mediastinum. So what you need to understand in this is like you take away the complete concept of needle, and then just use a cautery knife and then put cryoprobe, and then to get a good sample, because tissue is always guaranteed when you do mediastinal cryobiopsy. So 4 to 5 minutes, you get 5 passes, 5 samples of good tissue. So I think if in a very busy unit, this also decreases the time to perform mediastinal sampling, because the whole assembly of needle, getting it out, suction, all those things, you can save a lot of time in a busy unit, and then you can repeat the sampling very quickly. Sequential passes will be more easy to perform, and then you can also get more and more larger tissues by freezing the cryoprobe longer. So this is one advantage what we feel. So in our institute, we don't perform needle passes anymore. We just straight away do cryobiopsy and then quickly do the procedure. And play this video. And there are different ways how you create the tract. The needle tract I already discussed. And for those who question about the fanning technique, like you cannot sample different areas of the lymph node, it's not true that you cannot sample. You can still sample even using the cryoprobe in different areas. If you are not successful after from the initial hole that you made, you can make multiple holes and then see there is no much complications that are observed. And this is with an Olympus scope. You can see here, because when you talk on mediastinal cryobiopsy, the scope really matters, because the angle at which the instruments come are different from a Fuji scope to that of Olympus and Pentax. And the transducer distance in Fuji is much far away from the entry of the instrument to that of the Olympus and Pentax. So when you're doing cautery method, sometimes there is a chance of scope damage, especially with Olympus scopes when you use them. So, but still you can perform when you do it safely. Like here you can see, the only trick with Olympus scopes is like when you put the needle of the electrocautery knife, don't make it visible. You just press it into the mucosa and then make a deeper cut. And if you're not able to penetrate the capsule, then you can use the sheath of the knife to just make the passage a little more like how we put the center lines. You just make it a little more easy. And then the vision also matters here. Now you can see the cryoprobe goes in there from an Olympus scope from a top angle. The Fuji is straight, you can see, but from Olympus it comes from a little top. So you need to understand where the track is being made. And then you can quickly sample 3 or 4 procedures. And the big question here is whether the cryoprobes replace the current EBUS TBNA needles. We all know that in periphery and also in ILD, forceps are completely replaced, needles are replaced by cryobiopsy. So I think they will replace over a period of time, in my personal opinion, because there is a lot of evidence that is coming up, even in non-small cell lung cancer patients. This is one study coming from Switzerland showing that even in normal lung cancer patients, the IHC performance of mediastinal cryobiopsy is much superior to that of needle passes. But again, whenever there is a comparison, me and Professor Polete already had this discussion, that whenever there is a paper that is coming out comparing 2 different techniques, the parent technique will have a low diagnostic yield for some reason, maybe because we don't concentrate much on, like when you don't have the other technology. So the diagnostic yield here, if you see, is only 40%, which is not correlating with the other treatment. And coming to the new data that is coming up on lymphoproliferative disorders, this is the first paper looking at TBNA, and in the population they also did flow cytometry combined with the needle aspiration from Spain, and then they showed that EBUS has an overall diagnostic yield of around 95% in lymphoma patients, but EBUS TBNA combined with flow in the patients who had lymphoma as a diagnosis has only 25% diagnostic yield. Again, the population is very low to comment on this. And the last publication released yesterday is the role of mediastinal cryobiopsy in restaging in non-small cell lung cancer. And again, even in restaging after neoadjuvant chemotherapy, they showed that there is improvement in diagnostic yield compared to that of conventional needle-based sampling of the mediastinum. So, coming to the diagnostic advances in the periphery, we always talk on tool in lesion, and now the concept is lesion in the tool. So for EBUS also, we have this new technique called confocal laser microscopy, wherein once the operator does a mediastinal cryobiopsy, as in you can see here, once the tissue is acquired, there is a small negative charge mesh. We transfer the samples on that and then put into this machine called confocal laser microscopy, wherein you get immediate histopathology. Like instead of the rapid onset cytology, you can get immediate histopathology like images which correlate with the conventional histopathology, which takes around 3 days. And the advantage with this is, like when you submit these mediastinal cryobiopsy samples on this microscope has very deep penetration. It can slice layer by layer with a very high magnification compared to that of especially in benign disorders. Once you perform the procedure in 2 to 3 minutes, you can stain them, and then you can see nice well-formed granulomas as shown in this case. And we made the first publication on this. And then when we compare the first 4 cases of rapid histopathology versus the conventional histopathology, one additional advantage what the pathologist feel is like the stains that are used for this confocal laser microscopy do not stain the background RBC. So there is no smudging, and sometimes the pathologist may say there is a lot of blood. So you get over that problem here, and there is no difference between the digital histopathology and the conventional histopathology, both read by the same pathologist once you sample. So with this, my take-home message is like EBUS TBNA is proven superior to conventional needle-based TBNA approach. More data shows that in benign diseases and lymphoma, it is more useful. And the safety profile is already established with a lot of cases being published. And it will also reduce the need for mediastinoscopy in lymphoma, which is the only indication at the moment where we submit most patients for a invasive procedure. And cryobiopsy is superior to conventional needle-based TBNA even in molecular profiling for non-small cell lung cancer patients. And those who are interested in understanding the procedure well, we have a well-documented video on how we perform this procedure without using the needle on this Academy of Bronchoscopy YouTube channel. And also, those who are interested, we have Pulmonology on Air coming up, where we perform mediastinal cryobiopsy without the needle, and then you can watch it. Thank you.